Hello, everybody. Wow, this is good. There was the burble. I thought I was going to put on my professor hat and tell you all to quiet down. I may do that later if you get loud, though. So, thank you so much for having me here today. Housing California is an incredibly important organization, obviously state level, but also as a guiding light for the rest of the country. My organization that I'll tell you about in a bit works nationally. And it's a great honor to have the opportunity to speak here today. Seamus Roller, our past executive director, invited me about a year ago, actually, at least. And I was delighted to accept, not knowing that he would then move to San Francisco, is now walking distance from my house. So it was really lovely that having Lisa introduce me today. And I want to thank the board, the entire organization, all of our sponsors today, too. So what I'm going to talk about today is what you can see there on the screen, that health happens not in the doctor's office, but where you live, learn, work, and play. And the doctor's out, right? I am now taking care of patients more secondhand than I was for 20 years in order to have a greater impact. So what I'd like to do today is provide you guys, I want to sort of bring you around to why health is fundamentally what all of you are involved in, where some of the exciting new innovations are in terms of partnerships and financing affordable housing and community development, and I'm going to provide some resources at the end. It's kind of like, maybe not homework, but some opportunities to follow up on the topics I'll bring up today. So this photo here, this series of photos, this is from East Palo Alto, California. This is my first job after residency. And many of you probably know of East Palo Alto. At one point, it was the murder capital of the United States of America. And it struggles with a lot of issues. It's now struggling actually with gentrification. I arrived there with 25 years of education, 13 years post-high school graduation for medical school, residency, college. I told my niece and nephew at the time that I was in 25th grade, and they were not impressed. But I realized very quickly that all the medical training I had, my ability to take care of patients, was not, in fact, enough. I didn't know anything about the problems that were really facing my patients. It was things like language barriers, insurance status, legal status, the quality of the transportation system, the quality of their homes, the safety of the neighborhoods. And I was completely unprepared. Two very vivid memories that happened early on. One was a patient of mine with Down syndrome that had a very serious heart defect that happens quite commonly. And I had managed to get him his specialty care at Stanford Hospital that was only 2 miles away. I had managed to get him growing. He hadn't been eating very well. And managed to get him into a special education program designed especially for him and children like him. And I called the school one day before his visits to see how he was doing, because I was worried about his development, and found out that the family hadn't shown up recently. So he came in for the visit, and I talked to the mom, and she told me that her car had broken down. And there were no other rides, and there was no way to get to school. So I found myself calling the school back. They have a free shuttle service. But no one knew that. They didn't know what had happened to the mother didn't know to ask. So I find myself arranging transportation. Similarly, I had another child who was born prematurely, had serious lung disease, often happens if you're born 2 or 3 months early, was struggling with recurrent pneumonia. I finally started talking to the family. Again, keep in mind, I knew nothing about sort of context, which is kind of remarkable in retrospect. Turns out they had broken windows in their house, and the landlord refused to fix them. So again, I found myself writing letters to landlords. 25 years of education, and I'm organizing taxi cabs and writing letters to landlords. So it was a real reminder of the importance of this context and what really it is that affects children's health. So what I learned is that health, despite what we hear, is not health care. These are not interchangeable terms. Health care is really medical care. And frankly, we have too much medical care and not enough health in this country. So to drive that point home, this is a study that was done a number of years ago talking about contributions to early mortality. So early mortality, in case you're wondering, is before age 65. So anyone who's made it that far, it's not early yet. Healthcare is only 10% of the cause of what they now really think of health in general. So what is the rest of it? You can see here environmental exposures, behavioral patterns, social circumstances, genetic predispositions. The bulk, the ones that are lighter blue, are where all of you are working. It's factors that exist in the community, families making the choices that they have available to them. And interestingly, who here has heard the term epigenetics? Oh, a few, that's good. So epigenetics is the idea that your social context induces your genetic expression. So this paper is probably 20 years old or more. That 30% is actually much more driven by the social context than we realize. So it's really even more is in our control as affordable housers and community developers. But where do we spend our money? Healthcare, medical care. $3.3 trillion last year. That's a very, very hard number to wrap your head around. Does anyone know? Can anybody shout out what 1% of $3.3 trillion is? Any guesses? $33 billion. 1% of 3.3 trillion. It's a mind-boggling number. You wouldn't even notice if you shaved 1% off of the healthcare system, and yet it's $33 billion. The other way I think about it, because that's again a hard number, even that smaller number is hard to wrap your head around. Head Start in this country, per year, $7 to $8 billion. Per year, and we turn away half of all children who are eligible for Head Start. Why? Because we don't have enough money. You probably saw recently all the press around the Oroville Dam and the 2,000 dams across the country that are high risk of collapsing. I don't know if you saw the number they said that would be required to fix those dams. $20 billion. That's 2/3 of 1% of what we spend on medical care in this country right now. And I'll say, I was talking to Seamus this morning, I just read the Washington Post pointed out that in 2025, which by the way is only 8 years from now, which kind of is scary, they're expecting it to be $5.5 trillion for medical care. We're on a trajectory that's unsustainable. Important thing is that most of our expenditures are in chronic disease. Most chronic disease is preventable, and most chronic preventable disease occurs among low-income people living in low-income places. So people have estimated we're talking about $1 trillion play here. There's $1 trillion that if we do it right, we can free up within the current system. So what is health? This is actually, and why is it so expensive? So this is actually from 1946. This is the World Health Organization. What I've highlighted is complete physical, mental, and social well-being. Remarkably, that goes to 1946, right? It's not about the absence of disease and infirmity. It's about physical, mental, and social well-being. Basically, families living good lives in good places. So what are these things that prevent us from reaching good health? A colleague of mine, a mentor of mine, really described it this way. He said it's like a curvy road in the mountains. You're driving along, you're paying attention most of the time, but it's kind of, you know, you're reaching to the radio, you're swatting the kid in the back seat who's too loud, and you miss the curve, and a certain percentage of cars just plunge off that cliff and end up in a pile on the bottom of the cliff in the valley floor. It's horrible. The villagers down at the bottom of the valley are horrified by this. We have to do something. So they build a clinic at the bottom of the cliff. And what do? Well, they're still dying, so we need to build a bigger clinic. We need to bring in specialists. We need MRI machines and very fast ambulances and another MRI machine just to make sure in case the first one's full. This is effectively what we've done in the United States. 95 to 98% of that $3.3 trillion goes to medical care, not in health promotion or disease prevention. So what are these things that make it hard to stay on this road in the mountains? We like to talk about the social determinants of health. That's an increasingly common term. How many of you have heard the term social determinants of health? That's great. You know, that's new. As of when I was in my training, medical school didn't come up at all. But as recently as 15 years ago, and I've really found that the housers and community developers have really, it just makes implicit sense. So you can see a lot of them listed here. These are the very factors that my families in East Palo Alto were facing every single day, and what all the families and residents of your communities are facing as well. What they boil down to, though, and this is really where the thinking is that it really comes down to a lack of control over your life, a lack of control over your day-to-day. And this leads to something called toxic stress. Again, I'm guessing a lot of you have heard the term toxic stress. Toxic stress is, again, it's this lack of control. It's not about being an airline pilot and driving and flying a plane full of people across the country. Not that that's not stressful, or standing up in front of 1,400 people and speaking. Like, that can be stressful. But I can leave here and go have a martini afterwards, right? That pilot can go home and know that if her husband gets sick or her children get sick, she can take a day off work and not lose her job. That's the difference that starts to accrue around toxic stress, is you don't know how you're going to make your life work tomorrow or the next day or the day after that. And this builds up. This actually has, and this really is new over the last 20 years, this understanding. What we talk about is, how does stress get under the skin to cause disease? We knew for a while that lower income people have worse health, but there was a long feeling it was genetic. It's just their predisposition. What we now know is there are several ways in which this stress gets into the body. Your immune system. You're actually more likely to get sick as an adult if you grew up in unstable housing. They showed this in middle class or college students at Carnegie Mellon. They literally put cold viruses in their noses, and children who grew up in unstable housing and rental housing or moved multiple times as children were more likely to get sick than their classmates who'd lived in stable housing as children. Inflammation is really what underlies a lot of chronic disease like heart disease. The fight or flight response, your response to the other stresses in your life, whether you can calm back down again, is dramatically affected. And perhaps the most pernicious is the effect on children's brains. Children that grow up in unstable, dangerous situations can have permanent changes to their ability to manage learning and concentration and other important skills later in life. It's really now understood to be part of what leads to intergenerational poverty, and what, to me as a pediatrician, makes it so critical that we hold this, really our feet to the fire on this, and make changes immediately. So I want to show you, if health is not healthcare, what is it? Health is education. The more education you get, the longer you're likely to live. So here you have life expectancy at age 25. So on the left, in the dark blue, are individuals who have less than a high school diploma. On the right are people with a college degree. It actually continues up if you had graduate degrees, so I might live to be 130, we'll see. These are averages, though, and this is an important issue. You're not doomed to die an early death if you don't graduate from high school. And we know cases where people have made it through. It's just that much harder. This is health equals income. This is family income for children. This is percent of children on the left. In dark green are those living under 100% of the poverty level. On the right, in the light green, 400% of the poverty level. These are children with less than very good health. You can see that fully a third of the lowest income children have less than poor health, compared to less than 7% of the highest income children. But what's important here, notice that it's a gradient. It's not the relatively well off are fine and those less well off are in bad shape every step along the way. So if you know someone who makes more money than you do, they're likely, on average, to live a longer life than you do. This means this affects all of us. And it's because you can sort of picture the toxic stress, the instability can be eased the more resources you have. This is an important issue as well. So what you see here, from the left to the right, are African American, Hispanic, and white individuals. This is all income levels. This is now adults with poor health. You see the gradient exists for each group. So there are some subtle differences across the groups, but the important thing is that it's not a racial issue. Why do we see it show up in this country as a racial issue? Because of this, the percent of people living in poverty. You see in the orange, the darker orange and the yellow, that's the percentage of African Americans and Latinos that live in poverty compared to whites and Asian Americans. So it's the poverty, it's the setting that leads to the toxic stress and leads to poor health. So as we say here, people get sick because of their social and physical environments. The way a colleague of mine has said it is, your body is your sum record of your life's opportunities and hardships. That used to be said fairly easily, but we now know it literally affects individual genetic expression. It affects levels of hormones in some cases permanently, affects brain development. So this is now biological, which makes me question, why does the medical system treat housing differently than it treats lead poisoning, for example? So you probably heard this term, your zip code is more important than your genetic code. And that is sadly true. Zip code, actually more than anything else, we talked about income, we talked about race, ethnicity, we talked about education. Where you are born and raised and where you live currently is probably the strongest predictor of every type of imaginable health outcome. And that's why I'm here right now, because all of you are helping fix that. So how does it show up? If you haven't seen these before, they can be a little jarring. These kinds of differences show up in life expectancy variation in very small distances. Here's a map of Washington, D.C. with life expectancy at different subway stops. So in the middle of the city, anywhere in the city is 77 years. But you get out to the suburbs, 84 years. There's a 7-year life expectancy gap that you can experience just riding the subway. Here's another one. This is New Orleans. Notice right in the middle, that's the Treme neighborhood. 55-year life expectancy. Anyone know of a country or a part of the world where life expectancy is 55 years? Any guesses? You can put it in your head. Zambia. Sub-Saharan Africa has a life expectancy similar to that of central New Orleans. And you can see only 3 miles away, this is now life expectancy at exit ramps. Only 3 miles away, it's 80, which is about the average for the US. But New Orleans and DC are complicated cities, right? They have long racial histories. They've complicated political issues there. So this is Minneapolis-St. Paul, arguably one of the wealthiest, healthiest. It is one of the whitest cities in the country, but it's inarguably one of the best run cities in the country. And look there, you see on the lower left, 13-year life expectancy difference, 1 exit ramp apart. So when this came out, they did a series of interviews, and they actually interviewed a guy who lived off the exit ramp where it's red there. I said, what do you think about this? He goes, well, I'm going to move to the other exit ramp. And this is exactly, not everybody can move. Some can, we should provide opportunities for that, but not everybody can. So we need to get into that and figure out what's happening in that neighborhood. And really to summarize this part, this is really, you guys are in the zip code improvement business. For too long, those of us in health, public health and medicine, saw it as something you had to deal with, not something you could solve. That was really my most fascinating insight when I came to learn about the affordable housing and community development sectors. And it's really because we've been working side by side, looking at slightly different issues, but in the same neighborhoods. You can see here, this is a map of Los Angeles County, and on the left are areas of economic hardship, where places where you all might be zeroing in on your energy. On the right is childhood obesity. That's where I would normally be spending my time. They're the same neighborhoods, and we often don't talk. I bring this up because this is the Community Reinvestment Act conference that happens every 2 years the Federal Reserve puts on. So this past February, which is unusual, we had Risa Lavizzo-Mourey, the president and CEO of the Robert Wood Johnson Foundation, which is the largest health foundation in the country, which basically is the largest in the world. And she said there, speaking to about 1,000 bankers, we're likely to look back at this time and wonder why community development and health were ever separate sectors. And that's what we're working towards, so that we can really gain the expertise and the resources across sectors. So I want to now tell you about some examples of where I think things are really being done well. And I want to, then I'll move on to some new innovations. So the first example is sort of neighborhood level zip code improvement. How many of you have heard of purpose-built communities? Some. This is a great organization I would recommend you look into. They're based out of Atlanta. They actually have one of their sites is now in Oakland, in the Castlemont neighborhood. They began in the Eastlake Meadows neighborhood of Atlanta, which was known as a war zone. Well, it was called Little Vietnam, not because anyone Vietnamese lives there, but because it was a war zone. The rate of felonies was so high that on average, a family experienced a felony per year. 5% of the kids were reading at grade level. About 13% of the adults were working. 40% of the units were uninhabitable. Purpose-built communities stumbled upon sort of their approach that they have now expanded out to other parts of the country. And they created the Eastlake Foundation, which became the quarterback, which really kept an eye on all parts of the system simultaneously. And they focused on three major pillars: mixed income housing, cradle to career education, what they call community wellness. And they drive all of their resources to those three things, making sure that every single individual gets what they need. And what they're finding now is this is actually my photo. This is what Eastlake looks like now. Children are still 70% free and reduced lunch at the school. The children that were 5% at reading level are now 95% at reading level. And it's unbelievable, outperform every other elementary school in the entire metro region, including the wealthy suburbs. It's really remarkable. And what's incredible, they have this great graph. They show the scores and they show housing value. The homes with the other communities with the other really, really great elementary school turnout or sort of results. Homes here in California it's cheap, but in the $500,000, $1 million range. But big homes there, in this community it's a quarter, it's a third, it's a fifth of that price. And so it really is very different communities. This is their recreation center, open to everyone. This is their new middle school and high school. Isn't that incredible? Can you imagine giving the opportunity to go to that school? And just to prove it's real, that's me. That's Danny Choi, who's the executive director of the Eastlake Foundation, and Shirley Franklin, who some of you may recognize was the mayor of Atlanta and was the president and CEO of Purpose Built for many years. So it's not a one-off. So this is New Orleans. This is after Hurricane Katrina, one of the large public housing projects they've redeveloped into a mixed-income community. Again, these are my pictures. So that's Columbia Park, it's called. This is mixed income. This is a mix, unit by unit, townhomes, public housing, subsidized housing, and market rate housing. I mean, it's incredible. This is looking across one of the areas that's not been developed yet. And again, here's the preschool. Every one of their sites has a preschool involved, which I think is really a key part of it. We talked about the toxic stress in early childhood. But right here in California, we've got one of what I now see as one of the other best examples of holistic community development. Many of you have probably heard of Hope SF. Yeah, great. It's an amazing effort, and I first became aware of it a number of years ago, and it's gone through some ups and downs by all means, but I really believe now it's highly structured. Theo Miller is the executive director. He reports directly to the mayor. Many of you may know it's 4 of the big public housing sites in San Francisco that were not redeveloped under Hope 6 and are now going to be redeveloped under Hope SF. And one of the critical features that is not true in purpose-built communities, which has been one of the big complaints there, is that they are redeveloping them without displacing anyone. Now, it's made it much more complicated and much more expensive, but they're going to do it in a graded fashion so that folks are able to stay on site while these are happening. So actually, the first of the sites, I think it's Alice Griffith. Yeah, thank you. Alice Griffith just opened in the last few weeks. 100% of the prior residents moved into the new facility. Hunter's View was opened, I think, about a year ago. 80% of the prior residents were able to move into the new facility. It's really remarkable. So I want to show you just a little quickly again, this is a crazy scale, but this is Sunnydale, which is one of the first I've worked at. So this is Mercy Housing, and the related companies are working on Sunnydale. I'm actually on Mercy Housing's board of trustees now, so I'm the only doctor on the board, safely. So this has been really exciting. So you can see there, now look, they talk about the fact that the street grid doesn't line up. Now watch what happens there. So that's what it's going to look like. So you can see it's reconnecting to the street grid. And They're turning it into townhomes. So this is what it looks like now. And really, I spoke to the board of one of the advisory boards for UCSF just last week, and we didn't have photos, unfortunately, because I wanted them to understand that San Francisco has homes that look like this. It's frankly appalling. And imagine, for me as a pediatrician, the life of the child growing up in a home like this. It's unacceptable for one of the wealthiest cities in the world. My job is to make UCSF help fix that. This is what it's going to look like next. So again, it's got the trees, it's the treescape, the gardens and the playgrounds, and the hub, which I think really important. It's going to connect the community back out to the neighborhood. So I want to really talk about funding. I mean, you guys know a lot of those stories, but I think seeing some of the sort of what I think is some of the front edge of this type of work is valuable. So in terms of funding, some of the innovations. So the first is the Healthy Futures Fund. So this is an effort by the Kresge Foundation, Morgan Stanley, and LISC to incentivize building clinical care facilities adjacent to or within affordable housing. It's a $200 million fund, and my favorite example here is the Conway Center in Washington, D.C. And it's my favorite because, and it's really a reframing to some extent, it's making explicit the links to the social determinants of health. So this facility, let me just get, it's being run by So Others Might Eat. It's a religious affiliated food pantry. $90 million investment, 202 low-income apartments, 15,000 patients are going to be seen in the brand new clinic. Job training center will be there, offices and green spaces, and it's across the street from a metro station. So you can see when you start to embrace multiple social determinants of health at once, that's when we're really going to have the impact. I think one of the things that's held us back has been that too often the housers are building housing, the education folks are building schools, the facilities folks are building facilities, the clinics are going in willy-nilly, no one's thinking about transportation at all. It really requires all these things. And if the investments are going in individually, it's a little bit like, in my opinion, it's like dropping vaccines out of a helicopter onto a neighborhood and hoping for the best. You might drop out the window exactly the right number of vaccines that everybody needs, but as we know, unless you get everything in the right order, at the right timing, the right dose, you might as well just throw that money away. And that, unfortunately, is, I think, where we've been. And that's why I think health and well-being is a really good measure of success. It's really moving us beyond an outcomes or an output focus of how many units of housing or how many childcare slots to did people's lives improve because of that housing? Did children's development improve because of that childcare slot? This is hard, and this is why our colleagues in public health and medicine are going to be important, because we don't necessarily measure health very well, but we do measure better than you guys do. And it is measurable. So another example, just to give you some sense that there's some activity out there. So this is the Healthy Neighborhoods Equity Fund. This one is very exciting, especially because in California, this builds off of gentrification. So this is the, let me get this right. This is, oh, I didn't write it down here. It's the Conservation Law Fund, working with the city of Boston. And what they've done here is this is an equity fund. So these are private investors, banks and others, that are putting money in up front, which allows purchasing of real estate in neighborhoods that are likely to undergo gentrification. They did a health impact assessment to identify what are the criteria for neighborhoods likely to be gentrified in the near future. They're buying that land up front in a pool type real estate purchase. The investors own a slice, basically, not an apartment or anything, a slice of that real estate. And over time, as that neighborhood gentrifies, it harnesses that increased value to pay back the original investors. So it basically is harnessing gentrification. So they're rolling it out now. They've actually got their first major investors, which is ideal. And last one I want to mention, because there's two sites here in California, is Spark. How many of you have heard of Spark? Not that many. So this is Strong, Prosperous, and Resilient Communities Challenge. The focus is health, climate resilience, and racial equity. You can see there's a large number of organizations engaged in this. Enterprise Community Partners, the San Francisco Federal Reserve, Low Income Investment Fund, and I'm forgetting the last, NRDC, National Resources Defense Council. they're going to have, you can see there, 3-year efforts. $90 million have already been committed. 20 for upfront grants for building resilience in the community, and 70 in capital. They believe that's only the beginning if this works. So the sites that they were just named last week include, you can see here, Atlanta, Chicago, Denver, Los Angeles, Memphis, and the San Francisco Bay Area. So there's going to be a very intensive effort to really show this sort of holistic, equitable development can be done well and have the health effects that we want, with the intent of showing that we can invest in those. So I'll just rush quickly through these. A big idea going on now in the healthcare sector more and more is the idea of anchor institutions. And that term really refers to buying local, hiring local, and investing local. Too often, this really started in Cleveland with the Democracy Collaborative. Too often they realized they were actually sending their laundry to be washed in Pittsburgh because the laundry washer in Pittsburgh was charging 2 cents less per load than they were in Cleveland. No one was thinking about the fact of where those jobs were going. So it's about being intentional about this kind of work. Children's Hospital of Philadelphia co-invested with the city to create a community health and literacy center. There's now a free clinic for the city, a children's clinic, a library, and a recreation center. So the hospital itself took out the new markets tax credit dollars. It's kind of remarkable. The VITA Health and Wellness District, this is Stamford Hospital in Stamford, Connecticut, did a land swap with the Housing Authority on a big chunk of public housing was adjacent to the hospital. Hospital needed space to build that shiny new tower you can see in the back of the bottom picture. They land swapped that. The hospital owned property in smaller parcels around the city. They developed 7 small neighborhoods. So these are my photos again. That's the public housing at the top. And at the bottom is the 2-acre farm, which is where the residents can work. They use community benefit dollars in the land swap in that case. And this is kind of a shocking one. United Healthcare, the largest insurer in the country, has concluded that it is worth their investment in housing to keep their patients healthy. Insurers are incentivized in the right way because they pay if you're sick. Hospitals, in most cases in this country, frankly benefit by having more sick people come in. And that's, again, why we have so much medical care. So this right here is in Austin, Texas. It's called Capital Studios. It's for formerly homeless and single low-income adults. And they financed it through low-income housing tax credits. But they took one step further. Here, this is in Phoenix. This was Chicanos por la Causa partnered with them to purchase, it was $20 million, to purchase a 351-unit property that's being redeveloped into affordable housing. In this case, what my colleagues at United Healthcare told me was that the low-income housing tax credit was too complicated. Does that shock any of you? They said they were fed up with that. They just wanted to make they just made a direct low-interest loan. And when I tried to understand, they're very cagey, I will say. I hope there's no one here. They're very cagey, but what we know, they're doing this because it is saving them money. Let's be really clear, right? They're doing that. I believe what they've done is they've done some analyses to estimate that there will be some number. There's no requirement, of course, that the patients living here have United Healthcare, but they are covering a larger and larger percentage of Medicaid patients, homeless patients, formerly patients, or individuals they wouldn't have normally covered before. They're estimating that a handful of people moving in here will save them enough money to make up for the interest being lost. This is a really fascinating move. So with those sort of ideas, I just want to give you a few things here, and we'll close up. So I do want to point out over here on the left, and I'll raise them here. I just put a stack, if anybody wants these, if anything strikes you, I've got a jargon buster, and I've got some postcards talking about what our offerings are and what measure up. So let me show you here. So first off, do come visit our site. So we are funded by the Robert Wood Johnson Foundation. We're an arm of Public Health Institute based in Oakland. And our vision, as you can see, is communities where all people can live rewarding and healthy lives. We've done a lot of work to make this very accessible and try to bring folks in. So if you want, we send out a monthly newsletter called The Pulse, which we have actual journalists do the writing for us so they can, it's punchy and fun to read, believe it or not. So I encourage you to take a look. This is a great document for those of you who want some more resources. This is a colleague at UCSF who wrote this, and so it's heavily cited using the scientific literature, and we're pushing hard to have more research done. The jargon buster I mentioned, helps folks on both sides. The CDC means different things to different people. It's not just a big office building in Atlanta. Measure Up. For those of you trying to figure out how to measure, a lot of these efforts are being brought, or were done by both public health and community development colleagues trying to figure out how to measure health effectively. Crosswalk is a series of deep dive articles by our journalism team. See, there's one there on gentrification, on investing in health. We just published 2 recently looking at how hospitals and healthcare systems are investing in affordable housing, and they're intended to be very, again, sort of easy reading. Community Close-Ups is a series of case studies looking to see where examples exist of multiple determinants of health being addressed simultaneously, as I mentioned. And a Partner Finder. This could be particularly useful for a lot of folks here in this room because it's hard to figure out who should you be reaching out to from the public health side, or for public health colleagues, who do you reach out to on the housing side? And so what we've done is pulled into one place a number of different organizations that can identify who's working in your city or in your region. And so do come up and grab some of these if you'd like to afterwards. But I want to end with the big picture, and that's bright eyes. A colleague asked me once years ago if I could tell whether a child was sick right away, or whether I could tell if they were doing well. And I said, yeah, of course I can. And they said, well, why? What is it? And I was trying to describe it, and they said, do they have bright eyes? I said, you know, they do. And I've taken care of newborns for 20 years, and newborns, as you know, every single one of them has bright eyes. And we burn that out of them way too soon. And those of us here are working to maintain those bright eyes or to bring back those bright eyes, even for a glimpse among the residents and families that we work with. So for that, I want to really applaud everyone here, and thank you for having me today.